Hello again. Just checking camera, sound, lights, everything's working. I'm on screen. Brilliant. For those of you that don't know me, my name's Jonathan Downham. I'm an advanced critical care practitioner, Birmingham Heartlands Hospital in the UK, going through the COVID crisis like many of you. I'm producing what I'm calling a series of COVID Chronicles, but this is more of a teaching one than necessarily the resources I found on Twitter, as some of the other COVID Chronicles are. I'm going to base this one on a fabulous resource created by at SamIamUK on Twitter. Sam is a relatively new ITU nurse who's produced a number of resource sheets. Let me just show you her website on a site called, her blog called What Would Florence Do? And you can see there she's got a number of free resources. So you've got bedside safety checks, arterial line and transducer, arterial line sampling, bedside monitor, common tasks and observations, eye and mouth care and turning, and ventilation basics. Now, I've covered the ventilation basics. I'm probably going to cover some of the others at a later date, but the one I'm focusing on now, and this is aimed at those new to ITU or those who need a bit of refresher, is the common tasks and observations that we do with our patients whilst they're under our care. So I won't necessarily cover the whole of this sheet because you can go through it yourself, but I'm just going to cover what I consider to be some of the salient points. So obviously, and I've got a pen here that may or may not decide to work. Let's see how we go. Obviously, start of the shift. Sorry, interesting. Let's rub that out, start again. Right, so obviously, start of the shift. So you're getting handover, so you get handover from the previous member of staff. Sometimes they're very detailed, but often they're broken down by body systems. So the member of staff will either take you through the chart or take you through the patient systems, be it cardiovascular, respiratory, abdominal, etc., etc., etc. Then obviously introduce yourself to the patient. We always talk to our patients, whether sedated or not. Go over to them, say hello to them. Relatives will often ask us, do we talk to them? And we always say, well, I certainly always say, absolutely talk to them. They may hear you, they may not. If they do hear you, you're a familiar voice, but we will go and talk to them as well. Check out your equipment. Again, if you're not familiar with this, you need to make sure that all your equipment is working properly, that it's all plugged in, that it's all running okay. The other night we had issues where basically a lot of our equipment wasn't plugged in because we'd run out of cables to plug them in with. So that was just another issue we had to overcome. Then do a patient assessment, A to E. So I do A to E, A, airway, breathing, circulation, disability, etc. Just run through them. So you're doing things like you're listening and feeling to their chest. Now, we've stopped using stethoscopes in my unit, so you probably won't be listening to their chest anymore. But you need to assess their sedation levels. And we do that basically by talking to the patient. If the patient opens their eyes when you talk to them and can keep their eyes open for approximately 10 seconds but then close their eyes again, that's actually the perfect level of sedation. We don't want them so heavily sedated that they're just not going to open their eyes unless they're really, really sick or they're paralysed. If they're paralysed, then we want them very heavily sedated, obviously. You're going to be looking at their labs. You're going to be looking to see if their blood results are there. It's useful on the round if the blood results are already there, but you know, the doctors are perfectly capable of getting their own blood results. So if they're not there, you focus on the patient care. I'm sure the doctors can probably sort themselves out. We need to assess their lines. So the kind of lines they're going to be having. So they're probably going to have a central line. So that's going to be a line into the internal jugular. Probably. That's the most likely place you're going to find it, on the right or the left. You need to make sure that your drugs are attached to it, the taps are all turned on, and that the drugs are running as you would be expecting them to do. Make sure that it's not kinked anywhere and not twisted. Is the dressing dry and intact? Is that okay? Does that need changing? It might need changing at some point. Possibly not a priority, but it's certainly something you need to be aware of. Then you're going to be looking at the ET tube. So most of the patients we've got at the moment are ventilated. We are getting some off the ventilator, which is fabulous, but most of them are going to be ventilated, and most of them will be ventilated with an endotracheal tube. Some of them now are being ventilated via a tracheal tube, but we'll talk about that in a later video possibly. So the ET tube, you need to know a number of things about it. First of all, is it secure? Is it tied in securely? Not too tight because you're going to cause pressure, but tight enough so that it's not wobbling about, okay? It's the tapes that are keeping the cuff in. It's not the balloon at the end of the tube that's keeping the cuff in. A lot of people think it's the balloon's job to keep the tube in. It's not. It's the balloon's job to make sure that when the air goes in, it goes into the lungs and doesn't just come back up around the tube because of the positive pressure ventilation. We need to assess the level at the lips. Why is that important? Well, if the tube's moved in or out, we need to know, and the only way we're going to know that is by knowing where it is at the lips when we start our shift. So let's say it's 23 centimetres. If it's moved 20 to 25 or 21, then you know it's moved either in or out, which can compromise the patient's ventilation. Check the venous access. So like I say, the central line. They may well have peripheral access as well. So they're going to have one or more venflons, for example. You need to know how long those venflons have been in. If they've been 3 or more days, then it may be that they need to come out. You need to assess them. Policy in most hospitals says 3 days and out they come. But to be honest with you, sometimes you're going to look at a venflon, it looks like it's working perfectly well. You need to assess each on their merit. That's my opinion. That's not necessarily going to be your policy. You need to check the cuff pressure in the endotracheal tube. So the cuff is the cuff is at the end of the tube, and like I say, that's making sure that the air goes in and doesn't come straight out again. But you need to know what the pressures are, and the ITU nurses can show you how to do that. If the cuff pressure is too high, sometimes what happens is that the cuff can actually herniate over the end of the tube, which is obviously going to cause ventilatory problems. Check your lines again. Now your arterial line relies on its transducer, which is the clever mechanically bit that converts the mechanical signal into an electrical signal. That needs really to be the level of the patient's heart. If the transducer is below the patient or above the patient, that's going to affect the actual blood pressure reading that you get, and you may need to zero them as well. Again, you might need to ask the ITU nurses how to do that, but the transducer needs to know what atmospheric pressure is, in other words, what its baseline will be, so it can give you a good and credible reading. The tube, you need to have a look at the NG tube. The NG tube, a lot of our patients are going to be fed nasogastrically. If not all of them will be fed nasogastrically. And again, you need to check the length of the tube at the nose, because we need to know whether it's moved in or out. If it's moved in or out significantly, we can't be absolutely sure where the tip of the tube is. And there have been incidents in the past where people have been fed into their lungs because the tube hasn't been checked properly. Now, in my trust at the moment, the definitive way of knowing the tube is in the right place is a chest x-ray, which is checked by a consultant. They will look to see if it crosses the carina, which is where the right and left main bronchus divide. They'll see the tube going between the two. They'll want to see it go below the diaphragm, and they'll want to see the tip below the diaphragm as well. So you need to be very clear that that tube hasn't moved. The urinary catheter, they're all going to have a urinary catheter. They can't pass urine for themselves, and it's important that we know what their urine output is on an hour-to-hour basis. We're aiming 30 mils per kilo, so you need to be aware of your patient's weight. Make sure it's below the patient. Make sure it's off the floor, and if it's full, you need to empty it as well. And check its expiry date. It may be that catheter bag is due to be changed. Are there any chest drains in? So the chest drains, they could be left and right chest drains. If they are in, you need to make sure that they've got a fluid level in, which is covering the end of the tube. Otherwise, the patient's just going to be entraining air into their chest, which we don't want to happen. I have seen incidents of chest drains without any fluid in. You need to see, are they swinging and or bubbling? Now, swinging and bubbling basically means that the chest drain is still doing its job. There is still a cavity in that patient's chest which needs to drain, be it fluid or air or blood or whatever. If it starts swinging and bubbling, it may be that we need to review it and perhaps think about taking it out. Medication lines, are they labelled? Now, you will find that with a central line in and all the medications that the patient's on, that all the lines can get very confusing. And if you need to change one or assess one or see if one's kinked in a hurry, it's really useful to have that line labelled. I know ITU nurses can often be seen as a little bit anal, but there's nothing worse in a hurry when an infusion starts screaming at you because it's occluded and you can't work out which one it is on the central line. So it's useful to have them all labelled, and you need to know when they expire as well. A quick review of your medications. So let me just change this because I'm not really using this pen, am I? A quick review of the medications. Let's just rub this line out as well. Just to be sure, so go over the drug chart, see what medications the patient's going to be given, give yourself a rough estimate, and some nurses will write down a little crib sheet for themselves of the jobs that need doing every hour. So give yourself a little estimate of when the next drugs are going to be due. Are they going to be due in an hour, in which case you need to start getting ready now? If they're due in 4 hours, then you can leave it a little while and perhaps think about it later. But just be aware of the drugs and any unusual ones. Some of the patients will have their own medication supplied, some not so much, and there might be some weird and wonderful drugs you've never heard of, and hopefully you've got those. If not, you need to start thinking about it. Right, I won't talk about that. Right, so on the hour, sometimes more often, we'll be doing a set of observations. I think we're still fortunate in that we use paper charts. I don't like electronic observations because it makes it harder to see everything at a glance, but I do understand why we're going that way. But you will be recording your observations at least on the hour for most of the patients. So you're going to be recording their core obs, as Sam has put here: heart rate, blood pressure, temperature, O2 sats, respiratory rate, urinary output, possibly drain output, and any ventilator data. So the ventilator data is basically what mode of ventilation are we using, what tidal volumes, what pressures we're using to drive those tidal volumes, and the fraction of inspired oxygen or the oxygen percentage as well. We need to think about 2 to 4 hourly, repositioning the patient. So I was on a night shift at 10, 2 and 6. We repositioned all 20 patients. Nearly broke my back, but we had to do it. So we just did it as almost a backs round. That's an old word. But the patients need to be repositioned, need to be side to side or on their back. We need to keep an eye on their temperature. We need to check their blood sugars. A lot of our patients will be on insulin infusions. We try and keep their blood sugars reasonably tight, not as tight as we used to, but reasonably tight. So they'll be on a sliding scale. So insulin is something that a lot of our patients will be on. You'll need to check the absorption of their NG feed. So every 4 hours or so, you're going to be aspirating the NG tube. If you get loads of aspirate, it varies from trust to trust, and guidance is a bit variable as well. But some trusts, it's as little as 250 mils. If you get more than 250 mils, you stop the feed, you go back in time, you reduce the level of the feed. If you get less than 250 mils, you just put it all back and you continue, assuming they're absorbing as a consequence. Assessing their GCS and pupils, of course, assessing the patient's pain, and obviously that's a visual score with a lot of the patients because they can't talk to you and they're not awake. Now, there are visual scales out there. If you put assessing patient's pain in ITU, you'll get lots of visual scales. There's lots of useful resources. ICU Liberation is one. If you go to www.iculiberation.com, that's got some great resources about assessing patients' pain, for example. Need to reposition the ET tube. So the ET tube will often like that, or like that, or in the middle. If it's like that or like that, it's going to be causing potentially pressure on those edges of the lip, so it needs to be moved into the middle, and then just a bit like you're turning the patient, you're moving the tube as well, just to relieve the pressure on the various parts of the lips and the tongue that has the ET tube sitting on top of it. So as needed, as she says, we're going to be changing the infusions. We're going to be changing the infusion rates. Now, the common infusions, and I spoke about this on a previous video I made. Let's talk about the common infusions you're going to be seeing. So this is the bank of syringe drivers next to the patient. So we need something to keep the patient asleep. Commonly, that's going to be propofol. So the big syringe with the white liquid in it. It's a sedative. It's going to keep them asleep. It's used to anaesthetise patients in theatres. Then they put them on the gases, but we use them to keep our patients asleep. So propofol. or possibly midazolam. Midazolam is a benzodiazepine, much longer acting. Consequently, it takes longer for the patients to wake up. We used to use that all the time. We used to use morphine and midazolam all the time, but it takes ages for the patients to wake up. So now we usually use propofol and a strong painkiller, either fentanyl or alfentanil. So those are the two drugs you're going to see. So propofol, alfentanil, or morphine and midazolam. So that's to keep them asleep. Then, to support their blood pressure, if necessary, we'll probably see something called noradrenaline. Noradrenaline is a vasopressor, so it squeezes all those vessels. So when the patient becomes septic and they vasodilate, we use noradrenaline, which then squeezes all those vessels tight and improves the blood pressure. That's the most commonly used drug, and certainly one that we're using a lot at the moment. The other one that you may see is atracurium. This is a drug that's going to keep the patient paralysed. Why do we paralyse our patients? Because sometimes that's the only way that we can actually get them to ventilate properly. So we stop their muscles from doing anything and we just let the ventilator do all the work, and sometimes that's the only way we can get it to work. So if they're paralysed, they clearly need to be very well sedated, because being paralysed, if you're not sedated, is not a pleasant experience. And you'll know that they're not as well sedated as they should be if they're paralysed, because things like their heart rate will go up, their blood pressure will go up, they may start to tear, so tears may start coming out of their eyes. They're not crying, but that's one of the signs, okay? So if that happens, they're ventilated, they're paralysed, and those things happen, then it might be that you need to sedate them a little bit more heavily as well. We might be suctioning them quite regularly. So a lot of the patients will have inline suction. So it's a big suction catheter that comes out of the ET tube that doesn't need to be disconnected. And again, the nurses can show you how to use those. They're fabulous. You can suction all the way down the tube with those and get any secretions up. And they may or may not need it fairly regularly. And then what else? So that's probably it, really. Obviously, you've got to think about the drugs, like I said. We might be asked to remove various devices that have got at the end of life. So their central line, for example. If the patient's spiking temperatures, it may be that we're going to be taking the central line out and reinserting another one. So there's going to be jobs like that, looking after the people who are going to be putting those lines in, be they doctors or advanced critical care practitioners like me. You may need to be talking to the relatives as well. That's difficult conversations at the moment, I know. At the minute, we tend to call all the relatives in the afternoon, or we try and call all the relatives in the afternoon, although they do still call us occasionally. And I don't blame them. It must be horrible to be completely remote from somebody you love and trying to get information. It just must be horrible. So when they phone, I try and give them as much information as I can. And that's one other thing as well, and I want to say this, is that in ITU, sometimes there's an inclination to walk past a ringing phone. Please try not to do that. Answer the phones. The problem is that there's worried relatives on the end, and there's other colleagues that may want to communicate with you as well. I know that you might be busy, and answering a phone is the last thing you want to do. But if you don't, communication is going to become really difficult for all of us. So we need to answer those ringing phones as well. And the most important thing is look after yourself as well. Look after yourself, look after your colleagues, work as a team. There's no job below anybody. Consultants downwards are all getting involved in helping these patients, helping each other. We need to try and keep smiling through this. And we need to be aware of each other's stress levels and give each other a break every now and again. If somebody's not coping well, don't judge. Let's give them a break. They need some time out, and then they can come back and hopefully they'll be better for it. So I hope this helps. I'm going to be doing some more on the other sheets that Sam's done. As I say, the link to Sam IAM's sheets are in here if you want to go and look at them, if you want to print them out. If there's any other questions you want me to cover, then please just ask. But in the meantime, take care, and we'll speak again soon.